Hello everyone, welcome to my channel. I'm Dr. Saurabh Dixit and I hope you all have given the INICET. So whatever will be the results, that is one thing, but we should be knowing the important questions which came, and there were a lot of different questions coming from different resources. So don't worry about the results. If you have given INICET and if you are a successful candidate in INICET, that's great. And if you are not, then you have the NEET, and these questions can always be taken as a reference for your revision for your Neetpg also. And the students who have actually given INICET, they should be knowing whether or no these questions, the answers they have marked was up to date or no, what are the correct answers for these questions. So let us understand the concepts. So this is a recall. First of all, let me tell you, I have taken this recall from various resources which are available in online media and whatever offline we can collect it from the students. But let me tell you that it may be not an exact representation of the MCQ, but yes, more or less they have been taken from the students who have given. So I've tried to do the best compilation I could have done. So in total, I collected around 30 questions, approximately 30 questions that I have collected. Let us try to understand. These majority of these questions were strictly basics and basic oriented. There was nothing like a very hi-fi question, but yes, it's a very important exam. So all of had an eye on the exam related questions. Once again, the general surgery was very heavy. So there was a question regarding the damage control surgery. As you know, that damage control surgery is an abbreviated form of surgery where we control the damage. We don't correct the damage, we control the damage first. Then we send the patient for resuscitation. So if you talk about the phase 1, of any damage control surgery is the laparotomy that you do. And what is so special about this laparotomy? This is an abbreviated form of laparotomy. So we go for an abbreviated laparotomy. In this, what are the two things that you are going to do? The first thing that you are going to do is control any ongoing bleeding. So if there is any ongoing bleeding, you are going to control that. The second thing that you are going to do is you are going to control the what? Contamination. So how do you control the contamination? This is one very simple thing. You can control the contamination by giving a thorough lavage and putting the drains. We don't go for the permanent closure, we go for a temporary closure, and then comes the phase 2. The phase 2 of the patient is in the ICU, and what are you doing here? Damage control has been done, but now you have to make the patient physiologically also stable. Lethal tried, there is something which is known as lethal tried. Because of the ongoing injury, there is a physiological damage which results in acidosis, hypothermia and coagulopathy. So when the patient is taken to ICU, the aim is to go for resuscitation. You go for resuscitation, and then we go for phase 3. When we talk about phase 3, what are the important things? This is the phase where you go for definite surgery. So what are the things that we do? We do resuscitation, yes. We do decontamination, we do hemorrhagic control. But remember, as a part of damage control surgery, we are not going to do any vascular anastomosis. This will be done as a part of definite surgery. So those who have marked C, that is the right answer for this. So when we talk about neurogenic shock, what is the concept of neurogenic shock? This is what is very, very, very simple thing. Neurogenic shock is a state when there is central sympathetic failure. So central sympathetic failure is there. And whenever there is central loss of sympathetic tone, there will be something which is known as peripheral vasodilatation, and therefore the pooling of blood will be there. So there will be hypotension, and along with that there will be loss of sympathetic tone. So bradycardia. So bradycardia, hypotension and bradypnea, they are the classical features. So hypotension and bradycardia are classically seen in this case. Next is, there was a question on the X-ray given for sigmoid volvulus. This is a very, very, very famous question that I have been always been discussing. Just see. So this is a very old slide of mine where I used to discuss the flashcard. It's available on YouTube, a lot of platforms where I teach. So this is a very same question which I have been discussing, and if you see, we got a similar question, the X-ray showing a sigmoid volvulus. So again the question is, I always stress on a point, how to identify whether it's a sigmoid volvulus. You can see a classical coffee bean appearance. Coffee bean appearance, that is one thing that you know. Or you can say an omega sign, you can see an omega sign, or you can see a bent inner tube. So this is the outer part of the tube and this part is the inner tube. So you can say this is what is a classical bent, this is a classical bent inner tube sign, inner tube sign. But I am more interested in few important things. What are they? Let us try to understand. So when we talk about any volvulus, the first thing that I lay emphasis on, look at where is the apex. So apex is very important. Remember, in case of sigmoid volvulus, the apex is towards the right upper quadrant. Remember, as the sigmoid volvulus grows inside, this may even grow to left upper quadrant. So right to left is a shift when we see a large or a huge sigmoid volvulus. The second thing is, you get to see one line. So if you see here, I will show you something. So there is one line converging down, there is another line which is converging down, and there is one more line converging and fusing. So three lines fusing into one another. This is known as a Freeman-Dahl sign. So a classical orientation of a sigmoid volvulus is towards the right upper quadrant, whereas a cecal volvulus is having the apex towards the what? The left upper quadrant. Then here you can see the two air fluid levels. So two air fluid levels are classically seen, whereas in cecal volvulus you get to see a single air fluid level. So it's an easy question and sigmoid volvulus is the answer for this. Next is, there was a question on this match the following. I don't know whether all the options are right or no, but yes, this time we had a lot of match the following questions. So how do you go for the lesions and how do you approach them in diagnosis? So when we talk about thyroid, you know, USG guided FNAC is the gold standard. Why it is USG guided? Why it is USG guided? The answer is simple, very simple. You know, majority of the thyroid nodules may be a mixture of, you can say, solid and cystic. Solid is the tumor part, cystic is the necrotic, you can say, degenerate part. So if you go for a blind FNA is going to increase the risk of false negative reporting. So there could be a possibility when you aspirate it from a cystic part and then you give a report that it's a colloidal degenerative swelling, and then you ask the patient to go for observation. After 3 months the patient comes with pulmonary or liver metastasis. So it's very important you go for FNAC. Why we don't go for true cut? Because you know that thyroid is a very vascular organ, it's a vascular cascade, and also malignancy is having internal vascularity. So if it starts to bleed, the pretracheal fascia which is enclosing the thyroid will have a tension compartment developed, because of which there will be or you can say the vascular return from the organs will be impeded, and thus the return from even the larynx will be impeded, resulting in laryngeal edema and respiratory distress. And that is why, you know, post total thyroidectomy, a patient presents to you with sudden respiratory distress in the ward. What to do? You go for emergency bedside exploration of the wound and evacuation of the hematoma. The answer is not because the hematoma is compressing the trachea. It is because of hematoma, the venous return from the larynx is impeded, and this results in laryngeal edema. So thyroid, you know, breast, the best and you can say the gold standard is the true cut biopsy. Then when we talk about the lymph node has excision biopsy, and the Marzolin ulcer, or it was Marzolin ulcer or a sarcoma, we go for a wedge biopsy or a shave biopsy. So to confirm it, and then we can plan out an excision. So this is what is the best thing that we have. So thyroid, USG guided, breast, true cut, excision biopsy for lymph nodes. Even Marzolin ulcers also, if it is a small, we can go for excision biopsy. But seeing the context of this question and the options available, I would have suggested this sequence of the answer. Next is drug of choice before thyroidectomy. Before we go for thyroidectomy for a goiter to reduce this bleeding. Now this is here, it's a bit controversial question. It can be potassium iodide as well as PTU. Remember, the concept of the drugs is not to reduce the bleeding. The concept of the drug is to attain a euthyroidic status. So remember, yes, to achieve the euthyroid status, I would have said carbimazole or methimazole would have been good. But here if you see, in order to shrink the function of the gland, Ki would have been the ideal option. That is the Lugol's iodine. I hope you know about the Wolff-Chaikoff effect, stimulatory and or inhibitory, you can say stimulus to the gland. So this is where I would have gone for A as an option. Now, there was a question whether an old lady fell down and she developed a head injury, and there was an image given, and if this was the image which I have collected from the students, so this is suggestive of SDH. How it is SDH? You can see the shape, it's a concavo-convex shape. The question was that she develops headache and neurological symptoms few days after. So lot of clinical hints are given. SDH, you know, elderly patients with presentation of symptoms maybe few days later. It may be acute and chronic SDH also in certain cases. What is the source of bleed? So as you know that in SDH, the source of bleed is the middle meningeal artery. No, it is the bridging cortical veins. So try to understand, this is dura, this is the skull, and this is dura and this is arachnoid, and in between the dura and the arachnoid there are lot of vessels, and whenever there is trauma, you know the dura and skull are fixed but arachnoid is not fixed, so it's vigorously shaken, and that is the time when the veins which are weaker than arteries and the veins in between the, or you can say the vessels in between the skull and the dura and the arachnoid, that is the bridging cortical vessels, they tend to tear off, and that is the time when the bleeding shall start, and this is why it is bridging cortical vessels. When we talk about vessels, amongst them veins are thinner, and that is why it is bridging cortical veins which are the most probable answer in this case. Next is, there was a sequence based arrangement on in the RTA. This is again a recall based question. Again, it's a controversy. Why? Because try to understand the primary survey and the resuscitation, they are done simultaneously. So primary survey and the resuscitation are done simultaneously. So here, this is the sequence. I would have gone for C as the first thing, and then when you talk about primary survey, first we have to go for airway. So secure airway, and then stabilize the C-spine. However, you have to understand that this order is not always, you can say, a dictum. If you have any catastrophic bleeding, you could have stopped the bleeding first. So then we follow the order of C, A, B, C, D, E. So remember here C, then B, then A would have been the probable answer providing the options which are given here. However, you have to understand that resuscitation and primary survey are done simultaneously. Next is, vitamin B12 deficiency is a feature of, you know, there is something which is known as Cassell's intrinsic factor which is produced by stomach. So remember, it is seen with stomach also. It is absorbed in duodenum and jejunum. So here also, even some part of it is absorbed in duodenum. The least would be affected in case of D. So if it is ileal resection, if you go for a total ileal resection, then also you will see this. But remember, ileal resection is the answer of exclusion in this case. The next is, a patient referred from outside with acute necrotizing pancreatitis with collection on CT scan. So this is a necrotizing pancreatitis and the patient is on vasopressor. Remember, the patient is on vasopressor. That means patient is really sick, and otherwise if you use your common sense, if the patient would have not been sick and sinking, patient would have not been referred. So forget about anything you can do surgically. The first thing is, try to do a percutaneous aspiration under the USG so that you can remove the underlying, you can say, contaminated content. So C would be the best answer. Remember, necrosectomy would have been done only once the patient is hemodynamically stable. Remember, already CT has given you the dimensions of the, you can say, or the extent of the loss that you are having. So it's pointless that you go for this MRI right now. So this is what is very, very, very important. Then there was a question on BIRATS. I couldn't recall the question because the students were not giving, have not shared the image. I hope you know BIRATS is breast imaging reporting and data system. And BIRATS, what is BIRATS? BIRATS, LIRATS, TIRATS, PIRATS, this is a way of expressing in terms of radiology how close the lesion that you are seeing resembles with a malignancy. So BIRATS 0 is inconclusive, that you cannot conclude, so repeat. Therefore, you need to repeat. So therefore, repeat scan or alternate scan. You need to change the scan. So alternate scan. The second is BIRATS 1. BIRATS 1 is negative. That means there is nothing inside. What is BIRETS 2? The lesion that you are talking about is definitely benign. So in these cases, you need to go for nothing but an annual follow-up. Annual follow-up. When you go for BIRETS 3, this is actually written as probably benign. So when we talk about probably benign, what is the probability of it being benign? It being malignant? Less than 2% risk of malignancy, and that is why these are the patients where we go for 6 monthly scan, follow-up scan. Then you have BIRETS 4, which is suspicious. So when we talk about suspicious, we need to know what should be the suspicion risk. 2 to 95% risk of what? There is malignancy. So if you talk about the other things, we have 4A which is 2 to 10%, 4B is more than 10 up to you can say 50%, and 4C is more than 50 up to 95%. Then students, we have something which is known as BIRETS 5. This is suggestive, and when we talk about suggestive, how much suggestion we need? So suggestive means more than 95%. Remember, in both of these cases, you need to go for biopsy has to be done. What is BIRETS 6? BIRETS 6 is a case scenario where already you know the diagnosis. Suppose you are going for BCT in invasive ductal cancer. So you need to repeat the scan to be assured that whether there is no lesion in the contralateral breast or in the same breast, there are no other hidden lesions. So if you are doing the scan for biopsy proven CA breast, so biopsy proven CA breast, if it is there, then you categorize that as BIRETS 6. Then there was a question, one more question from BCS. It's a straightforward question from, I have been discussing it for a long time. Yes, history of prior radiation is a contraindication. Remember, active SLE, active scleroderma. So active SLE, active scleroderma. Remember, multiple tumors is a relative. Remember, tumor less than 4 centimeter size, less than 4 centimeter size, this is not a contraindication, neither is the D, large breast. I don't know whether the recall is correct or no. So both B and D are not the contraindications for BCS. Remember, breast conservation surgery can be done. However, technically in large breast it becomes a bit difficult. So I would have said either the recalls are not good, but yes, tumor less than 4 centimeter and D, large breast, both are not a contraindications for this. So alcohol based sanitizer must be used after, must not be used in examining the patient. In what case scenario? If this was a question with visible soiled hands, so if the hands are soiled, you need to wash it. So you will not be using the alcohol based sanitizer for this purpose. So there was a question, direct question from Doctrine of Monroe Kelly. I've been teaching it for a very long time now, and I'm very happy that this year I got a question. You know, Doctrine of Monroe Kelly says skull is a closed vault. Any addition to it is managed by egress of CSF in venous blood, and it is given as a beautiful equation that CPP is equal to MAP minus ICP. So there could be a question on whether the MAP is given, whether CPP is given, and ICP is asked, or ICP is given, they ask for CPP. So this was a very straightforward, simple question. Then there was a question on visible mass in the epigastric region. So remember, it is CCT based assessment, or I don't know what this was the recall. So there was a visible mass in the CT on epigastric region with the CD117 positive. So this is a very strong marker for GIST, because lymphomas are positive for S100. It could be, but not for CD117. So yes, this is a gastric GIST probably. Probably it's a gastric GIST. It's a very, very, very simple question. I hope you know GIST is gastrointestinal stromal tumor, and the stomach is the most common site of this. What are they? They are the smooth muscle tumor arising from the interstitial cells of Cazal. However, they are not exactly the smooth muscle tumors. Next is not used to diagnose breast cancer. Radiology, yes, is very important, because radiology will help you in localization, biopsy will help you in confirmation, and clinical examination will help you in assessment of this. Remember, this together forms the concept of what? Triple assessment, and this is what is very, very, very important. When we talk about PET-CT, PET-CT is used for metastatic workup of any cancer. So remember, when we talk about PET-CT, it's very obvious that we use the PET-CT for metastatic workup. So it's very, very, very simple for us to understand. So answer is A. A is not a question, the option that is correct. So when we talk about the SIRS, what is SIRS? Systemic Inflammatory Response Syndrome. So when you talk about systemic inflammatory, this is a very, very, very famous throwaway level of question. Systemic Inflammatory Response Syndrome. What are the things that you need to understand, students? It has 4 parameters, that the heart rate is more than 90 per minute, respiratory rate is less than is more than 20 per minute, or remember, because of this increased respiratory rate, there may be what? PaCO2 less than 30 or 32 mmHg. Along with that, what else do you get to see? Temperature of the body more than 38, so both hyper or hypo, less than 36 degrees Celsius. And then WBC count more than 12,000 or more less than 4,000 per mm cube. So remember, respiratory rate is important, pulse rate is important, temperature is important, but SBP is not a parameter that is included here. Then there was a question on pneumothorax, and there was a question on what should be done. So yes, a stab injury with a patient of pneumothorax, we would have gone for intercostal chest drain insertion. Now in this case, we need to assess whether this pneumothorax, the question was that there was a very simple question, I couldn't get the complete things. If this is a pneumothorax, then the first line management or the treatment of choice would have been a classical intercostal chest drain insertion. If it would have been a tension pneumothorax, then also the same. If it would have been a tension pneumothorax with unstable patient, you know, intercostal chest drain should be done, but before that, decompression with the what? Needle. So needle thoracostomy followed by tube. Ultimately, tube would have been done. Same, there was a question on the boundaries of triangle of safety. So I will discuss that later. So gas under the diaphragm again is a straightforward question. If you see my last predictable series of top 15 questions, most predictable, the first question that I have asked was a peptic ulcer disease question. So gas under the diaphragm, what is the next thing? Answer is we need to go for laparotomy. So laparotomy is what we need to do. This is the definite, you can say, treatment of choice. But however, try to understand what is the, you can say, what will you do next. So if you have a patient with gas under the diaphragm, the first thing that you need to do is the resuscitation of the patient, because if it is hemodynamically unstable, you cannot take the patient for the surgery. So first resuscitation and followed by surgery. So A followed by C would have been the answer, because INICET is known for its, you can say, confusing character of the question. So this is a very easy question, but yes, what should be done next? If you have a patient of gas in the diaphragm, you cannot say, okay, chalo, let's directly take him to OT. First you have to give some fluid, stabilize the patient, then you have to take. So this is what is the answer, A followed by C. Benefit of laparoscopy, you know, I am a laparoscopic and robotic surgeon, so I always condemn any form of open surgery. The first thing is, the best cost message, not better, the best cost message. It's painless. Why it's painless? I will tell you, because there are very less incisions made over this. Next is early ambulation and long term to time to discharge. Today, majority of the centers have converted into the laparoscopic centers into daycare centers. So answer is D, which is highly incorrect in this case. Next is a 19-year-old girl with 6 months swelling moving with deglutition and muscle invasion. Remember, swelling moving with deglutition, there could be two things. It could be a thyroid swelling. First is it could be a thyroid swelling, or the second option, it could be a thyroglossal duct. But why will a thyroglossal duct present to you with features of muscle invasion? So again, one more thing is, the thyroid swelling moves with deglutition, whereas a thyroglossal duct cyst will move with deglutition also and with protrusion of tongue. So there is no comment on this. So it's a thyroid, and there is a muscle invasion, so it's a cancer. So try to understand amongst them what are the options that we have. Remember, the invasive nature of medullary cancer is the maximum in this case. So C would have been better, far better answer than A in this case. It's a medullary CA because medullary CA is known for its dubious nature of local invasion also. So C better than A. So D you have ruled out. Why? Because a thyroglossal duct cyst moves with deglutition and also with protrusion of the tongue. Second is it is benign, so there is no muscle invasion in this case. Same is the case with follicular adenoma, it will move but there will be no feature of muscle invasion. Now amongst A and C, medullary is more associated with the risk of invasion. Order of correction of hypospadiasis. So first thing that we do is the orthoplasty. Remember Caudy correction. So orthoplasty is what we do first. So orthoplasty, and then we are planning for the granulo and the myetoplasty. So orthoplasty, granuloplasty. So it is the most important thing. The first thing that you need to understand is we go for Caudy correction. So orthoplasty, and then we go for granuloplasty, myetoplasty and urethroplasty. So granulo, myeto and the urethroplasty. This is how we actually go for. Next is number of nodes removed in each cancer staging. I think if there was a matching type question, breast you remove 10, stomach you remove 15 is the ideal count, so 16 if it was given. Colon is 12 and gallbladder anywhere more than 5 is justifiable. So I don't know what was the question, it was a match of following question type. So this is the correct sequence of the answers. Patient presented with hematuria. So if you see here, there is a left renal mass with hematuria. What is the diagnosis? So remember, anything which is confidently observable on CT scan, remember it is only AML, and AML because of the fat as the basic content can be confidently diagnosed on the CT. So if you see the fat ridden arrow marked, they are the fat ridden lesions, and that is why it is angiomyolipoma. I hope you know angiomyolipoma is tortuous blood vessels. Along with that, the fat, along with that, you have the the smooth muscles. So tortuous blood vessels, angiomyo means muscle, smooth muscles, and lipoma means fat. So next is which should not be given before splenectomy. So you know that before splenectomy you need a prophylactic vaccination. Now when we talk about prophylactic vaccination, there are 3 vaccines which are standardly given 2 weeks prior. So 2 weeks prior to surgery we give H influenza, meningococcal, pneumococcal. Typhoid vaccine has no role. Remember, if it is done for elective, so this is for elective. If you do it for emergency splenectomy, always remember, I have discussed a lot of times this concept in class, within 2 days you will give the H influenza. So H influenza is given within 2 days, and after 2 weeks you shall give the meningococcal and pneumococcal vaccines, and this is what is very important. Elective 2 weeks prior and emergency 2 weeks later, except for the hemoinfluenza. Now gallbladder cancer, there was a question that the early findings, remember painless obstructive jaundice. So painless obstructive jaundice, and what is the reason for this obstructive jaundice? It is nothing but the compression of the CBD. So painless, so painless obstructive jaundice, this is one thing that we have. And then we have the palpable gallbladder mass. So palpable mass with painless obstructive jaundice. So jaundice better than B. Even there could be features of acute cholecystitis also. Acute cholecystitis like features can happen. So A is better answer. For safe resection of proximal transverse colon, this is again a very simple question but very important question. So when we talk about transverse colon, so let me draw this image, and if you go to my colon notes where I have discussed colectomies, I have drawn the diagram in each case and shown it to you. So when we talk about the proximal transverse colon, so first thing that you need to know what should be the extent. But before that, this is superior mesenteric artery. Let me make a superior mesenteric artery trunk for you, and out of which you have the major middle colic trunk, middle colic, and then this is the left branch of middle colic, and this is the right branch of middle colic. Then you have the ileocolic, this is ileocolic, and this is the right colic vessel. And then you have the IMA, inferior mesenteric, from which the left colic, the sigmoidal and the superior rectal branches are arising. So you are going for a proximal transverse colon tumor. So when you're talking about tumor or a proximal transverse colon, I'm talking about tumor, it's a transverse colon, then you need to go right up to the splenic flexure. So you go for extended hemicolectomy, extended right hemicolectomy, and that is the place where you need to ligate a lot of branches. So you ligate ileocolic also, right colic also, and trunk. So if you see what you don't ligate, you will go for ileocolic ligation, trunk of middle colic, right middle colic, right branch of middle colic. Remember here the trunk of middle colic is the most important vessel. It is, what are the vessels that we ligate? Ileocolic also, trunk of middle colic also, right colic also, but right branch of middle colic is not ligated. Why? Because we ligate the trunk. So what should be the answer in this case? B is not the vessel which we don't ligate, rather we directly ligate the trunk. So most common site for ileocecal TB, this is a very easy question for a country like India. TB is very important problem, and we had seen a lot of questions in different sets. So it is IC junction, stomach is a rare site, stomach is a rare site. So IC junction is the most common site. It's a throw forward question. Then you had a question on rat tail sign, string sign of Canton, football sign, inverted umbrella sign. So there are a lot of things. Now here the rat tail sign, you know, achalasia. Okay, I understand it is more common in malignancy, but achalasia would be the good answer for here. Football sign you get to see in pneumoperitoneum. Inverted umbrella sign you get to see in case of TB, ileocecal TB. Remember string sign you see in TB also, but here you can see in hypertrophic pyloric stenosis also. So this is what is the correct order for the match the following. Again, you know the triangle of safety. So you have pectoralis major, then you have the mid axillary line, and then you have imaginary line towards the nipple areolar complex. So obviously this is going to be pointing at the level of fifth intercostal space, So this triangle that you can see, this is what is known as a triangle of safety. Now when you talk about, again a very simple question, a case of a clinical scenario given of a partial bowel obstruction, partial, remember, so surgery is not mandatory, weight loss, stricture in the bowel. So bowel obstruction, weight loss, stricture, very simple diagnosis is the inflammatory bowel disease, or you can say intestinal tuberculosis in a country like India. So I would have easily gone for a trial of ATT, and if it would have not survived, then only I would have gone for a stricturoplasty or maybe a resection. So this is what is very simple and straightforward management in this case. Then my favorite topic, there was a question direct forward on the sutures, and I have discussed it a lot of times. Many of the times you might have got irritated also, but I know that these questions will be asked. So polypropylene, you know it's proline, and proline is an ideal suture for hernia repair. Then we have polygalactin 910 and polydiaxone. So somewhere I think there is a controversy in the recall. Polygalactin is a suture which we preferred for bowel anastomosis. Even polydiaxone also can be preferred. Now someone has said skin closure. If skin closure is the answer, then there is no suture which is used here. Rather, if it is abdominal closure, then I would have gone for polydiaxone as an answer here. Remember, when we talk about nylon, nylon is a suture of choice for tendon repair. I couldn't get the exact recall, so whatever I have got, I have just written it. So this is, again, there was a question on CA prostate. A system EB scan was done, which is showing the uptake. Why this is known as a super scan? Because it is used to evaluate the metastatic spread. That is why system AB scan is a super scan. I couldn't add the image because there was an image, but I was not sure what it could be. So this is because of it is depicting the metastatic spread. That is why probably it is known as a super scan. Then there was a question on post appendicectomy. On exploration, there was some bleeding. So during appendicectomy, so what is the vessel? That is very important. If you see my videos, in this fold of Treves, or here you will find the mesentery, and in this mesentery you will have the appendicular artery, which is the branch of ileocholic artery. So it's a ileocholic artery or appendicular artery which is actually a part of this. So students, this was a brief recall session. I hope you enjoyed this, and do take it as a positive motivation. Don't you can say take it negatively that you could have done better and this and that. You have the NEET exam right forward. Press the gas pedal. Yes, if you are able to make through that, then it's great. It's great. If you're not able to, NEET is still waiting for you, where you have far better chances. So even if you don't perform good in the INICET, that doesn't mean that you cannot be a topper in Neetpg. So take your confidence to the level best that you can, and do revise these questions. Do revise the questions of other subjects also. Take it as the hot running topics in the market, and definitely you all will be able to be successful. So thank you. Do subscribe to my channel. Do comment in the comment section how you liked, or whether you want a recall video, or whether you want a revision video on any other topic. Till then, bye bye.